Hi everyone, welcome to the From Prescription to Participation Social Prescribing and Physical Activity webinar. We're going to get started in a couple of minutes. So just for now, use the chat function to maybe introduce yourself, your role, your organisation, and what brings you here today. Just give it a couple more minutes for a few more people to join. Brilliant, we're all using the chat, lovely. Right, let's get things started. So thank you everyone for joining us today for this Social Prescribing and Physical Activity webinar. It'll be myself, Zoe, and my colleague Tom hosting the webinar today. And we're joined by some brilliant guest speakers from across the world of personalised care. So Tom and I both work in the health team at the Heart Sports and Physical Activity Partnership, or HSP, and are seeking to better embed physical activity into primary and secondary care health settings through our Active Connections programme. So this webinar sets up one part of that work, and we're aiming to explore how physical activity, how your physical activity offer can support health professionals, how you can reach new audiences, and overall how you can help to tackle inequalities. When we started this Active Connections programme, we were struggling to get our heads around social prescribing, what it looked like nationally and locally, and really what it was. We went on to realise that many of our partners were also having similar conversations, particularly through the physical activity sector, who wanted to better understand social prescribing and also how to better connect to them. So we got to work on setting up some steering groups, so both with the social prescribing sector, but also with the physical activity sector. And we were able to demystify some of those conversations around social prescribing and its connections to physical activity. We wanted to share the information on this webinar in the hope that more partners can understand this topic better and create some really meaningful impact with your own organisations. So before we go any further, I just want to touch on some housekeeping. So you should be remained muted throughout the webinar. That's in the webinar function. So live captions are available for anyone that needs this function. You can see on the screen there how to do that. Questions can be asked throughout. Use both the chat function and also the Q&A function for that. We'll be going through all the questions at the end of the webinar. So our speakers are going to stay on in case anybody's got any questions. The webinar is going to be recorded and distributed to those registered for the event. So anyone that isn't able to attend can catch up. And the other thing that I should mention is we're in PowerPoint live mode, which essentially means that you will be able to toggle through the slides yourselves. So you might, if you end up doing that, you might feel like you've got lost and I might be talking about a different slide. So just make sure that you're on the current slide that I'm talking through, because you'll be able to toggle them through yourselves. So without further ado, it's probably worth saying, first of all, who we are. Now, HSP is an active partnership, and I know we've got representation from other active partnerships on the call today. So we're one of 42 nationally, and we cover the span of Hertfordshire. And we come with a vision of getting more people more active more often. We receive core funding from both Sport England and from our local authorities, and we work very targeted to tackle inequalities through physical activity. We work with a lot of system partners, and a lot of the work today will focus on how those health system partners and physical activity providers can better connect. And we're based at the University of Hertfordshire, and although we are based there, we're very much community focused and work across the whole county. So looking at the main agenda for today, we've done our introduction, and we'll shortly be hearing from Tracy Lyons at the National Academy for Social Prescribing to give us an overview of the importance of social prescribing and the integration of this within the physical activity sector. We'll then be hearing from local personalised care partners to hear about their differing roles, as well as some of the case studies to share some good practice from across the county. We're then going to summarise with some real tangible next steps and priorities for you to take away from today. So to get us started then, please welcome Tracy Lines, Physical Activity Lead for the National Academy of Social Prescribing.
Hi, thank you, Zoe. Hi, good morning, everybody. Lovely to be with you, and hopefully I'm going to take you through a little bit around social prescribing. So yes, I work at the National Academy for Social Prescribing, where we do all things social prescribing, and hopefully going to explain to you now a little bit more about social prescribing, how it fits and how the physical activity sector really links into that, and what's going on kind of nationally at the moment, as obviously we're in the midst of lots of change with lots of new things happening with the 10-year plan and all kinds of different things. So hopefully we'll give you a bit of an insight into what's been going on and what's happening at a national level, and then how that really interlinks and important down to place. So next slide, please, Zoe. So just to help Zoe, there's a few clicks. If you click through, it'll all then like underline under the main parts, or I can do that if you want me to take over. It's not a problem. Brilliant, thank you for that. So this is the international definition for social prescribing. This was done by a Delphi study internationally, to really, as everybody was kind of scratching their heads as people do, go, whoa, what actually is it? So this is the definition for it. So it's the means of a trusted individual in clinical or a community setting identifying a person with non-medical health-related social needs and connecting them to non-clinical support and services within their community by co-producing, and that's really important, that co-producing a social prescription. So it's really about ensuring that what is developed is what matters to that individual. It's personal to them, where it links into the personalised care agenda, and how you can really work with them to look at that prescription and improve their health and well-being and strengthen community connections. And obviously within all of that, the physical activity sector has been doing this work for a number of years, and then over time social prescribing as a kind of an adverb has kind of come around, and people talk about it more and more. So that's the international definition. It's about that connection, and I'll show you what that kind of looks like and can look like in place, and it can be very different in all areas of the country. It's not a kind of a one size fits all. Next slide, please. So just giving you some national context is where it all came from and where it's now going is it started to be spoken about more social prescribing in that context of really tackling loneliness back in 2018. And then in 2019, there was a marked change where the NHS incorporated social prescribing into the comprehensive personalised care model, which you'll hear more from people who work in personalised care later today. So that hopefully will bring that to life. So those roles started to be described in that, and then it moved on and it started to be spoken about in GP contracts, in PCNs, in primary care networks, that they must deliver social prescribing, an element of personalised care. So it moved from being spoken about in national policy to then the NHS kind of taking that on board, and we were the first country to actually really take social prescribing and embed it into the health system. And now there are many other countries we work internationally as well that actually are now taking social prescribing and embedding it into their healthcare system, and some that have overtaken us as a nation and actually doing more, particularly down kind of in Japan, and those areas are really working around it. So it started to develop further. And then at the same time, in 2020, what happened was DEFRA and partners with government decided to do a national pilot around green social prescribing. And that's only just come to an end. So there's been a period for around nearly 5 years now of actually really understanding how do you embed, how do you make links with healthcare professionals, actually also referring people to green movement-based activities into their place. And there's a raft of research, and we've got a green social prescribing innovation network which people can join. I can send some links to after this to help people if they would really like to understand that and find the evidence that came for that, but I'll nod to that a little bit later. And then also in 2022, Department for Transport also wanted to look further around social prescribing. So it went from just health, it went into DEFRA, it went into other partners. Sport England were part of the Green Social Prescribing National Pilots. And then a number of partners came together around active travel social prescribing pilots. And they're still happening at the moment. That pilot work is still going on, much more research going on into that. And then Also, Beyond Pills came around for the College of Medicine campaign to really think about how do we support people rather than just kind of doing that pill, actually beyond that, and more work, and a parliamentary group was established. Next slide, please. Then, obviously, in 2023, there was the expansion of personalised care roles across England, and that was built into the NHS workforce plan. And then there started to be talk around NHS Fit for the Future, which now are actually into the new government, and we've now got the 10-year plan that's just been launched and talking much more around neighbourhood health. But when it was talk around an NHS Fit for the Future, there was lots of talk about social prescribing and how we can support people and benefit from activities all around. And obviously, physical activity has a key role in that, and I'll come on to the number of referrals, and we know all about how many people are being referred to physical activity, etc., nationally. And then now there's a big focus on getting people back to work, and I would say out of all the areas from that we talk to with government on a regular basis, back to work is one area that they're really considering about how to utilise social prescribing as a way of working and supporting, and how it can be embedded within different roles, not just into the NHS. And then there's been a call also for a national strategy for children and young people social prescribing, which I've actually been developing, and we've now got a vision for children and young people social prescribing, which was launched earlier this year, and now there's going to be a big momentum on pushing forward, because it kind of was waiting also for the 10-year plan. So hopefully that gives you some background into social prescribing. It isn't just about in a GP practice, it's much wider than that. It's much into many other areas that they're starting to look, and I can go into a bit more of that a little bit later. Next slide, please. So who is social prescribing for? It's basically it started off that it was for people with one or more long-term condition. So obviously physical activity has got a really key role there in terms of supporting people with long-term conditions, supporting people around their mental health and well-being. That was specifically what has been looked at for the children and young people's vision for social prescribing. And also that was looked at for the national green social prescribing pilots. Mental health and well-being were the key kind of conditions that was looked at there. Those are those that are lonely and isolated, those people with complex needs affecting their well-being. And then the list is growing, particularly around young people that are actually not in school, so those not in education and training, also looking at young people in the justice system, looking at people in the adults who unemployed currently. So looking in lots of different areas as it's starting to grow and to develop, and moving across lots of different kind of sectors rather than just sitting in the health system. Next slide, please. But what is needed? There's a lot needed in terms of really supporting those individuals. And one of it is really raising the profile of that. So there's lots of work that goes on to raise the profile of people to understand social prescribing and how they can build social prescribing into their roles, if as an individual, if they're working, but also for the general public to understand and ask around social prescribing. So lots of work is going on around looking and thinking about that, because we're actually also a bit at whereas actually people would think, oh, well, I'll go along and actually be prescribed, dare I say, medication, but actually how can we prescribe actually activities within their community and be as valued as that? So there is work that's happening around that. There's also work happening around there's no wrong door, which is really where sometimes people think and say to me, like, how do I get to link workers? What I need to do is just work with link workers, and actually thinking, how do you work with a much wider workforce, and how there is no wrong door for an individual, for people to also understand how to be signposted to social prescribing link workers if that's relevant for them, or actually how roles themselves can actually take on that role of kind of supporting people with what matters. And then obviously having really accessible, funded, which is really important, activities that is relevant for those people to take part of. And that can be quite challenging for the community and voluntary sector, and at NASP we understand that, and we're doing quite a large piece of work on looking at how we can develop a community health and wellbeing fund with government to really fund activities to be able to ensure that people can actually be referred to them, and they're funded long term, not that they're scrabbling around for funding on a kind of year by year basis, because that makes it really difficult to have a sustained programme. So lots of work going on to that at the moment as well. Next slide, please. And within this, can you just click through, Zoe? Thank you. obviously within social prescribing, there's the individual themselves. They're what matters most importantly. Then there's people that can identify someone that needs some help and support. There is a connector. That's what matters. And in the health system, that's a link worker, but it doesn't have to just be them. It can be other people. And I'll come on to what the research just showed us. And then obviously there's the prescriptions. And then in terms of those activities for those people of what really matters to them. And it doesn't necessarily mean that it's one thing. It can be a multiple of things. Actually, how they all work together and actually how they work together in a system is something is really important. And then most importantly is the data tracking about how you really show the improvement for those individuals. Particularly, we get asked a lot about that nationally by Department for Health. How can we show the impact of what social prescribing has had on people's health and well-being or on different conditions? And actually, how do you show the return on investment for that? Which I know isn't easy, and that is something that we're trying to do more and more work around. And we've recently established a national data centre for social prescribing with University College London to really try and help and support with actually providing the data and showing the impact of the great work that prescriptions are doing and how the system, when it's all working together, can work really effectively. Next slide, please. So the identifier, people can kind of say, well, people tend to think, oh, they're a GP or a different healthcare professional, but they can be from a multiple of roles, particularly around integrated neighbourhood teams. It doesn't have to be just in the healthcare system, particularly around children and young people. It could be a school teacher, it could be a school nurse, it could be a youth worker, it could be a whole array of different people that can identify and really understand that somebody needs some help and some support. And obviously that's also important that they understand what social prescribing is. So it's actually that going back to that education piece around that. So that's kind of looking at your identifier. And dare I say, to just blow your mind a little bit, your identifier could also be a connector. So you can depends a lot of the time about who people trust. And particularly we found that with children and young people, that actually particularly we've got young people within the physical activity sector where actually they're coaches or kind of the people that they're group leaders. Actually, they could be the people that can also support those young people with really what matters to them and really help and support them. And there's quite a lot of detailed work going on at the moment with Rugby League Cares and a number of national of the English Football League Trust, really thinking about how we can help and develop that work further in the future. So you've got the identifier. Next slide, please. And then you've got the connector, and the connector is about the social prescribing and understanding that what matters, having that what matters conversation, and then co-producing a plan with an individual. The NHS invested in social prescribing link workers that either can be through R's funding, can either be based in primary care, or can be actually commissioned and delivered in another area. But we are seeing that those types of roles are growing across local government, public health are funding them. We're seeing it coming in a number of different areas and in a number of different ways. So it doesn't have to be just in the health system. It can be much wider than that there are those connectors. But the most important thing is it's about those roles having the time and the skills to have that what matters conversation and being able to co-produce that plan. And there's further work at the moment happening within the physical activity sector about thinking how we can support and upskill the sector that have been asking from. We've done a national discovery exercise to understand what can we really help and support the sector with. And a lot of that is actually being able to hold those what matters conversations. That's come out through the national kind of research that we've done so far with a number of organisations. Next slide, please. And then the really important bit, the prescription. And obviously physical activity is really key within this. There's obviously information and advice also, but the two can go hand in glove. There's obviously things around the natural environment, such as green, which obviously physical activity fits in there, and arts and culture and heritage, and physical activity fits in there. So physical activity can fit in across all of those areas. What we do know, there's always been a bit of a kind of myth that people say, oh, we're not sure if people in the health system understand the benefits of physical activity. And we've just recently done the National Link Worker Survey with NHS England, and we found that 96.5% of link workers did understand the benefits of physical activity. And what we also know is that on a regular basis, that they've told us, of the 5.2 million referrals that have been made from just in the health system around link work, around social prescribing, that 77% of those are actually regularly on a weekly basis prescribing to physical activity. So, but what we also know is that people say to us from in the health system, actually, we understand the benefits of physical activity. We are referring some people to that, and I'll come on to a slide in a minute to show some of the barriers that they're seeming to be finding, which some of it blew my mind a little bit from working in physical activity a very long time. But also what they're also saying is we want to know how we can work much more collaboratively together with services. So it's not just about kind of going along and saying we offer this to a local provider. Actually, how can we work together to co-produce a program that actually can be worked with what matters to the people or what matters within a practice to their population? So it's really thinking about how to work collaboratively together rather than just saying, actually, we're here, we offer a walking program. How can you really work together? And how can then we really look at the data to show the return on investment of that within the health system, which we're doing some work on at the moment around that, to really look at how we can build those better connections at those places. And there's a number of pilot sites happening across the country. Next slide, please. And then we also asked link workers, and a few healthy lifestyle coaches were involved in this within the national survey. We asked what the main barriers were, the most common barriers that people faced. And within physical activity, which we found was a bit like, and we all sat in one way scratching our heads, was that 42% of people stated that the barriers that people faced was cost. And we wondered if that started to be around perceived cost, because we also know, obviously, there's much in the physical activity sector that is, free to use provision. And also we've also found in terms of self-care and self-help, there is not a lot really going on there. So when we started to look at that in more depth, and which we're doing some further detailed deep dive into this data with UCL at the moment to understand that, and looking at the referrals, where they're going, whom they're going to understand that, and find out why that's the case. So we also started to recognise that there was some perception of actually what physical activity is, and actually thinking about actually how we position physical activity locally in places so that people do understand the benefits of it, rather than seeing it sometimes as when we spoke to a focus group of some link workers, not all, but some were talking to us about actually it's around into like leisure provision, and there's a cost associated there, and that would be a barrier to our patients. So actually thinking in other ways about how you really build and co-produce together a provision for their patients, and how you work collaboratively is something that we've been doing some further work around. Next slide, please. And what we know from prescription perspective is what is needed is we know that funding is needed, and in some areas we have seen across the country there's community chests and obviously funding around that to enable those community organisations that deliver brilliant pieces of work, some really comprehensive programs and funding around that. That's one area that may be needed in some areas. We do know that there needs to be the encouragement of just self-care rather than just the referral, around how we really embed that within. And we found that we've just recently done a national explore around prescriptions, where we've had a consultant going out talking to people who deliver prescriptions, and we're speaking about how we embed self-care, and that's something that we feel there is starting to be needed a little bit more. But also what we do know, and there's no surprise here, that works really well is that social element. That cuppa in a biscuit is obviously really important to most people, and also supporting people in terms of those buddy schemes, all of those types of schemes to really support people along to activities at first is really, really important. Some people with link workers in the past, unfortunately now they work so hard and they are so busy that sometimes they don't have the opportunity now because of their caseload to be able to actually support people to activities. But the more that actually the prescription can actually link and work together and look at how they can connect that can be really, really beneficial. That's what we found in some areas, and that came out a lot through the national green kind of, so it's not rocket science, but it's something that needs to be kind of considered moving forward. Next slide, please. And then there is also something called proactive social prescribing. So you've got your social prescribing, and then you've got proactive social prescribing. And proactive social prescribing goes one step further. And this is where practices actually can go into their practice record and actually identify targeted groups of people with unmet needs that they would like to work with. And we're doing a lot of work around this, around physical activity, saying actually, if we can do some preventative work around working with practices to consider how they can actually go and work within their doing their targeted proactive social prescribing, and then working collaboratively with a number of organisations around physical activity to either work within practice, work alongside the practice, work together, is something that we've started to see. We've seen a number of areas of the country have done this, and it's been worked really, really well. And it's also worked well because we were able to work back and track the data and show the changes that have happened. So practices can do that if they so wish. It is within the DES contract in 2022, and that's part of personalised care. And some places will be doing it. But if you are a physical activity provider and you're wanting to think about how to really link in and work with alongside, that could be a way in to talk about, well, who are you really trying to target in your practice? And sometimes that's people that are high intensity users of that practice. It could be that they're recently looking, lots of places are looking at people at risk of falls in the next 5 years. Other people are looking at people at risk of cardiovascular disease. So obviously all of those things physical activity can be very, very beneficial for. But how could you work together with the practice around that, and also that helps and supports that? So that's something that can be considered, and we're doing some detailed work on that at the moment to really show how to do that, and how to also support the practices around that, because that's something that we found is really needed. Next slide, please. And when we look at the proactive social prescribing, it starts to move into, I call it a little relay team, to really understand that kind of those personalised care roles, which you'll hear from in a moment, how they can work together in sometimes delivering groups or working in partnership with the local, whatever is in place in terms of physical activity, whether that be local walking groups, etc., but seeing them as part of a team rather than just we're here, you're there. How do you work collaboratively together? How do you then work to develop a small consortium of physical activity providers to really wrap around and support that MDT team, that multidisciplinary team, ensuring that the activities are relevant and right around what matters, and kind of co-producing that together around the needs of patients and understanding that. And then obviously providing that kind of physical activity consortium within that wider community, and how they can kind of hand them out, pass that relay baton on to other provision. We've seen some really good areas around neighbourhood working, where people are really working collaboratively, 50, 60 organisations working together to actually support people kind of in that relay, moving them through and actually supporting them in those areas. So it's really thinking about how you can work collaboratively together with other organisations, and how you can work in that way, and then that data flowing, which I make it sound so easy. I know it's much more complicated than that, but really thinking about that. And we're doing quite a lot of work around that at the moment to really see. And we've seen some, and it starts to work very, very well. Next slide, please. So that's a lot about adults. Children, I'd say it's quite different. It's definitely a different approach to adults. Some areas of the country do have specialist link workers that are funded through the health system that are children and young people's link workers, and I think you're going to hear from one later today. But we also know with children and young people that there are people within school settings, there are people within youth settings, etc., that are taking a social prescribing approach. So it's quite different to the adult model. It can be delivered in schools, it can be delivered in primary care, but we're also, and obviously in the community. And we've developed a national vision, which I can send the link to. And we've also done a big piece of work around training and development for children and young people, social prescribing. And then on behalf of Sport England, we've done another piece of work to understand the prescription needs of children and young people, and the needs of people providing their prescriptions, because particularly what's raised here is around supporting young people with around their mental health and well-being, and what training and development is needed. And we've been doing quite a lot of work around that with NHS England as well, and looking at how we can embed social prescribing, obviously, for children and people in national strategies and partnerships. It's not as developed in national strategies at the moment, but we've been doing a lot of work with Department for Education and a lot of work with DCMS around that to really embed it. How we can grow the workforce across the system, because there isn't hardly as many children and people's link workers that are funded through the health system as there are adult at all. Some areas don't have them at all. It's a real postcode lottery, but also thinking about other roles that can work in those ways. And we're seeing a much more growth of that. And then supporting and delivering those high quality social prescriptions and systems to really support those young people at the right time, both in prevention and in treatment services. There's lots of research been going on around waiting well for children and young people waiting on CAMHS lists, etc. It's been done through UCL. That research is just coming to the end, which has been really, really successful. And then obviously that investment to create sustainability within places, and then again building awareness. We do know from working with NHS England that parents, particularly of children that are on CAMHS registers, are actually much more hesitant to actually enable their child to go to other activities rather than just into the CAMHS services. So how do we build that? How do we look at that? That's something that we've been considering. So there's lots on children and people, not going to go into real depth, but there's loads on that we could go into, and there's whole models and whole system models that have been looked at around children and people's social prescribing. Next slide, please. But with all of it, it's about a whole system approach. Hopefully that's come across from this. It isn't just about having an activity over here and link workers over there, or your personalised care roles. It's how they really can work together and work in collaboration to work in that whole system and really think about, and it can be through an array of roles. It's not just sometimes a link worker in the health system. A number of places can be working, and it all depends on the place, and thinking about how organisations can really work together to ensure that seamless pathway for those people around what matters to them. And then just a little bit, next slide is nodding to the future, really. So what is also emerging? Next slide, please. You'll have heard of the NHS England's neighbourhood health guidelines. Obviously, social prescribing is listed as a key function within that. The new neighbourhood health guidelines and the neighbourhood health services will happen over the next 5 to 10 years. The guidance for that is being developed, and a few colleagues have been in meetings around that with NHS England and other colleagues and Department for Health at the moment are thinking about that. And there's really looking at how we really focus. Obviously, at the moment, there is focus there. The priority groups for 25-26 in those models are adults with moderate or severe frailty, those with palliative care needs, and then with physical disabilities, and children who with wider needs input, and then those kind of high intensity users are the kind of the key ones at the moment. But that's emerging. People will be starting to talk about that. Some ICBs and local authorities have had to bid in to be the kind of the first areas for neighbourhood health services, but that's kind of where it's moving forward going. So watch this space. There'll be guidance and kind of areas coming forward with that in the future, I believe. And I think that's it from me. So hopefully that's giving you an overview of nationally what's going on. There's loads going on in lots of different areas. And yeah, it sits in the health system, and it's really, really important, but it's definitely brokering out and going into lots of other areas as an approach and a way of working. So thank you.
Thank you, Tracy. A very brilliant introduction for kind of just starting to demystify the world of personalised care. And I really like the breakdown of the identifier, the connector, and that prescription. And I think we'll see that a lot with our next speakers. So without further ado, we're now going to go on to a breakdown of what those personalised care roles look like. This is not an exhaustive list. There's so many different roles, as Tracy's already outlined. But this is our chance to hear from some of those individuals working within those roles, tell us a little bit of what their day-to-day looks like and how it might differ from another role. As Tracy outlined as well, you know, they're not all in that healthcare setting. We've got 2 from a healthcare setting and 1 that's not. So we're going to be hearing from Inez, who is a CYP social prescriber. We're going to be hearing from Louise, who is a health and wellbeing coach within a primary care network. And then we're going to be hearing from Caroline, who is up first, who is a social prescriber at Hatfield Primary Care Network. Caroline's going to be outlining her role as a social prescriber, how it fits in with that local primary care system, touching on her experience with Hertfordshire Health Walks, as well as how she's integrating with the personalised care, the physical activity sector. So Caroline, take it away.
Oh, hi, my name is Caroline, as Zoe said, and leading on from the social prescribing that's already been described, I'm going to just talk a little bit about how we manage this in Hatfield. So as it's been said already, patients with social prescriptions get better and feel better faster than those treated just with medicine. So it's a very person-centered sort of role and situation. It's complex and it's always changing. It depends on that patient who comes to the GP surgery or is out in the community. Each person is very different. Next slide, please, Zoe. So in Hatfield, there's 5 of us, and we've got 4 surgeries that we cover. And there's about 55,000 patients across Hatfield. And we work directly with between 800 and 1,000 patients per year. And we've increased over the last 5 years. So it's just one of us to start with 5 years ago. And each year our PCN have added another one of us, which has been brilliant because the caseloads have got much bigger and the complexity of the patients we work with has got more complex, I guess. So we try and work in the community. We are based with 4 of the surgeries, but we don't sit in the surgery and have patients come to us. We're mainly out and about. So we work in the community, we meet in all sorts of different places, which I'll go on to discuss a bit further. But that includes meeting people in the food bank, meeting them in their homes, meeting them out on walks. We do quite a lot of coffee drinking, and we do lots of visits to leisure centres, swimming pools, football pitches. We've been to all sorts of random places actually, but we work very closely within our PCN team, so we've got other people within our team that we can work with. Can we have the next slide please, Zoe? So the wider determinants of health are the core of what we're doing. So we are non-clinical and we're looking at all the things that have an impact on why patients are going to the GP too frequently or very frequently, and we're also looking at those people that don't go or have got all these different factors in their lives that impact on their health and their well-being. So we're looking at their work environment, their living conditions, their employment, their childcare situation, their frailty, their self-care, their housing's massive, their confidence levels, their mental health levels, their unemployment, all the things that have an impact on people's health. Not just age, sex, and their actual factors of where they live. So next slide, please, Zoe. So we look at so many different things. We look at finances. We look at mental health is massive. People being more socially connected and living more independently. So it's not us guiding people too much. It's about us facilitating them to be able to make some changes for themselves. Finances is a massive one. We do lots of benefit checks and lots of support with the Citizens Advice Bureau, who work really closely with them. Can I have the next slide, please, Zoe? So I think I've said this already. It's very person-centered. We have a caseload of patients that we are given by a whole range of people, and it can be the GP predominantly, but it's also the mental health workers, social workers, somebody at the food bank who's a volunteer might notice somebody who needs a bit of support, and they will talk to us as the connectors. We meet with patients for practical and emotional support. We really work hard on building strong relationships with loads of other organisations and community groups. We try and reduce the GP visits if we can, because a lot of people are going to the GP because of mental health, because they're lonely or they feel socially isolated, not just about physical activities around the physical health, but about their social connections as well. We work closely with the 5 steps to mental wellbeing. We're trying to reduce hospital admissions, obviously, and help and support patients to stay safe and very independent in their own homes. We find this with a lot of older people who are quite determined to stay quite independent and at home, but we want to prevent them from having falls or ending up being in hospital. Work a lot with loneliness. We work with befriending services. We provide, you know, connections for Meals on Wheels, aids and adaptations for people. We've got a walking service, cleaning and shopping, attendance allowance, groups and activities, adult care services, referrals, dementia support, bereavement support. It goes on and on. AA there actually is as well, Alcoholics Anonymous, and working quite closely with Change, Grow, Live and the addiction services. We look at safety, we look at pendant alarms and staying safe. We get fire service to come out with people who are hoarders. We do blue badges and bus passes, all the things that will help connect people outside of the clinical. Next slide, please, Zoe. We do a lot of form filling, and we go to people's houses. Sometimes, you know, you might go to do a blue badge and then you get there and realise there's loads of other things that we can do to support somebody, to get them out of the house, to get them doing activities, to get them outside. We do grants for people. We try to help access opportunities of volunteering and work. We work with families and children's services and schools. We work with patients for some time. Some people I've had on my caseload, I've been doing this for 5 years, and some people are on and off my caseload throughout that 5 years. Other people have been on there 2 years. Some people are on it for maybe a couple of months and then they're gone. Some it's one visit and you can resolve, but they're all very different. There's no quick fix for some people. We have to listen a lot and we have to be quite patient, which I struggle with sometimes, I must admit, but we have to be patient. We have to build up trust. People tell us the things that they haven't told other people about, that's the barriers that are stopping them from being able to manage their own health and well-being, and stopping them from using the gym, going swimming, going for a walk. So we have to build up a bit of trust. And I think because we're not a GP and we've got longer, we can take that time. We have to be very creative. We have to use emails or phone. We stand in the street with people. I've stood outside people's doors. I've you know, followed them into the GPs before. We've got lots of people who are agoraphobic or have got learning difficulties, disabilities, mental health issues that stop them from being able to engage. So we have to be very creative. We do meal planning, we do health walks, we try and access outdoor activities. So we walk with patients. We have quite a few patients who don't want to talk looking at you. They're quite happy to walk alongside you and talk. And that's how we find out what it is that they need for them. We help people access food banks. We help them go to the gym, attending badminton or bowling. I've done all sorts of activities that I thought I would never do, but I've done those with patients to encourage them to go to these activities. Next slide, please, Zoe. So some of the examples we've got are, you might go for a referral for a blue badge for a patient, and then you visit them and find they've actually got no food, no social contact, they're hoarders and they've got lots of mental health issues, but they wouldn't necessarily show that or present that when they go to the GP or when they're, you know, going to ASDA, for example. So once you're in someone's house, it gives you the chance to find out more about them and then help support them with those areas. So we've had lots of referrals for, you know, people who are agoraphobic. So I've had a patient for quite some time now who was homeless since he was 14. Lots of social anxiety, lots of agoraphobia. So I had to go to his house regularly. No support, no family. I had to work really slowly to build up trust with him, opening his mail that had loads of hospital appointments, obviously they hadn't opened, helping him with his admin, getting him out for a walk and considering social groups. Now he now can go to the GP by himself, and I managed to get him to the gym in Hatfield and worked really closely to do an induction with the personnel at the gym who worked one-to-one with him, and he's still going to the gym and he goes out for walks and he's got a bigger social network now and doesn't ring me as often. So that's quite a good case study. Next slide, please, Zoe. We get patients out walking and talking. So we realise that people like to talk and get out. So we have done projects like we've all become health walkers, Hertfordshire health walkers. So we did the qualification and we run our own social walking group on a Friday. We also did a Let's Cook project where we worked very closely with our local food bank to provide basic food to patients and how to cook things in a more healthy way. We had a healthy eating group. We've encouraged people to go to park run. We've started doing park run ourselves to get people there. We do local bowling and swimming groups, and some of the no strings badminton groups that get other people, our patients, to be quite sociable, and walking football. So we've been doing a walking football group with a potential kids in Hatfield who do an inclusive football group for children with autism and ADHD. Next slide, please, Zoe. So social prescribers are like detectives. We make contact with the patients, either face-to-face or on the phone, and then we work on the issues that I've discussed on the slides already. I wanted to just give a couple of other examples. That I've mentioned the healthy walking group, the Heart's Health Walks, and we had a healthy eating group that we ran for 6 weeks. And some of those patients from that group, we did stuff on proteins and carbs and microbiome and things like that. Some of those patients that came to that group hadn't been out much, and they now are friends. They go for coffee, they go for walks, but they've also, two of the ladies in that group have become health walkers themselves. So they're now volunteering and they're out. They've lost weight, they go to the gym together, and they've made those social contacts. We've also got, individuals. So I've had somebody who's 56 who was suicidal, on antidepressants for a long time, had a stroke, and the GP suggested park run, which he obviously didn't want to do. So we went out walking quite a lot together. Then we ended up walking at park run, and now he's about to do his 50th park run. He's come off his antidepressants. He's lost 3 stone in weight, and he's made some very good social connections through the park run. And he recently got diagnosed with cancer, but managed to get through the surgery for that cancer really well because he'd lost weight before and because he'd been quite active. The other sort of case studies, I don't want to go on too many because we've got loads, but we've also got coffee mornings and social groups where the patients, we go and conduct those, but the patients then tell each other about local activities that are going on, or pair up and go with each other to physical activities. So that's working quite well. And we've got one patient who's actually 79, who I worked with her for quite some time when she'd got a broken hip, and got her a befriender. And now that she's better and up and running, she is a befriender herself. And she recently started to do chair yoga and has found the benefits of the chair yoga so brilliant that she is now doing a qualification to become a teacher of chair yoga herself at the age of 79. And she's already showing other groups in our social coffee mornings how the chair yoga is supporting her physical health. She can get on and off the toilet easier. She can reach cupboards easier. She can get in and out of the car easier. So lots of very small but very significant health changes. I think I've also mentioned a co-production, working really closely with Men's Shed in Hatfield, who want us to do a Nordic walking group, I should say, and working with potential kids in Hatfield, working with the children, getting people into their garden, going to the gym with people. I mean, the range of things that we're doing is pretty lengthy, and I think I've said enough now. Zoe is looking at me, so I think I've finished my slide. So thank you for listening.
That was brilliant, Caroline. And I think just particularly with those last case studies that you shared, I know we've got a proper case study section after, but I'm really glad that you fitted those in, because I think it really shows the power of the work that you do and the power that physical activity can provide to this whole personalised care sector. So there's some lovely ones. I love that one about the park run and the chair yoga as well. So thank you very much. We're now going to pass over to Inez, who is a children and young people's social prescriber. So Tracy touched a little bit on that CYP social prescribing. Inez sits within Watford Football Club Community Sport and Education Trust, and she's going to outline her personalised care role and how this might differ from a usual social prescribing role.
Hi everyone, so my name is Innes and I am a CYP Health and Wellbeing Project Officer at Watford FC Community Sports and Education Trust, like Zoe just said, and I've been doing this for 3 years. My programme is called YouthLink, and it is a social prescribing service with the aim to provide young people with support and direction on how to improve their physical and their mental health by signposting into local community provisions. The programme also targets to educate young people's awareness of their mental health and to empower them to understand their own well-being and how to cope with daily life stresses. Our footprint is covered by Hertfordshire and West Essex ICB. However, the service is funded by the Watford Boroughs Council Neighbourhood Grant, and it's currently match funded with the West Herts charity. Next slide, sorry, please. So the programme is specifically designed as a Tier 2 early intervention prevention service, supporting children and young people experiencing with low to moderate mental health difficulties that do not meet the threshold for specialist clinical services, so like CAMS. A lot of referrals we see of young people coming in with low self-esteem, low confidence, and refusing to go to school. The programme offers 6 face-to-face one-to-one sessions over a period of 6 months' time, whilst also providing signposting according to each individual's interests and needs. Sometimes signposts can vary depending on the young person's confidence, and they might get signposted straight away and continue signposted whilst attending the wellbeing sessions, and some people prefer to get signposted at the end. So it really is individually based on the young person. The programme accepts all types of referrals. It's an open referral programme, so I accept young people over the age of 16. They could self-refer if they feel like they need support, parents and carers, GPs, SENCOs, or any other professionals involved in the young person's care. We also have a referral pathway with the paediatrics department at Watford General Hospital, so they can signpost young people to come to the programme and receive support for their wellbeing whilst being seen at Watford General Hospital. In addition to this, we have also created a pathway with CAMS to help their waiting list. So if there's anyone with low to moderate mental health needs and they feel like they might need support with coming to YouthLink instead of coming or waiting for CAMS, they will get referred into the service too. So once I receive a referral, I normally will carry out an initial triage to assess whether a young person is suitable for the programme. And if they are, then I will normally book in the young person and the parents come in for an introductory session at the stadium, just to go through what the programme consists of, any signposting that I can do straight away so that they continue with the signposting and answer any questions, because sometimes I do the triage early in advance, so by the time they do come to the introductory session at the stadium, they've forgotten all about what the programme consists of. Next slide, sorry. So the programme aims to provide young people with support and direction during their wellbeing check-ins, in their one-to-one sessions, educate young people's awareness of mental health and their own mental health and how they can cope by introducing coping strategies and how to put them in place and how to use them, and empowering young people to understand how to cope with daily life stresses. Next slide, sorry. So YouthLink is aimed at children and young people aged 10 to 18 years old. We previously had this opened for children and adults, so 10 to 24. However, we didn't really get much referrals from over the age of 18, not much engagement, so we've reduced the age limit to 18. The young person must be registered with a doctor within the West Herts area, so Watford, Three Rivers, Dacorum, Hertsmere and St Albans, and it's suitable for individuals with low to moderate mental health doubts, issues or conditions. YouthLink is also inclusive for young people with SEND needs, so we have a few resources to support them, such as social stories or visual videos where they're able to see what's going to happen before they come to an introductory session, so they are aware of where they're going and the sequencing of the programme. Next slide, Zoe. YouthLink sessions, we're quite lucky that we are able to use the club's dedicated sensory room for our safe space for our one-to-one sessions. It it keeps our sessions in a calm and fun environment. They get to see the pitch outside. Young people tend to quite enjoy where they have their sessions. During these sessions, we discuss any struggles that they may have regarding their mental health or any barriers they may face and how to overcome this by putting things in place. Each young person is offered an individual support plan based on their own needs, goals and interests, and this is all individually led by the young person. No one will have the same support plan as everyone is different. The support focuses on improving mental health awareness, building self-esteem and confidence by developing practical coping skills to help young people manage their daily life stresses. And obviously, I will signpost them depending on their needs and interests to community provisions such as Watford Community Sports and Education Programmes. We've got many that are out in the community and they are free of charge, but also services for young people, young carers. It really is depending on why they've been referred and what they are looking for support with. Next slide, Zoe.
I think that's all.
Finished.
I think that's all. Yeah, because then we're going to pop back to your case study. So,
Okay.
thank you so much, Inez. So yeah, I know that we're popping back to case studies in a minute, and it'll kind of really bring to life even more the important work that is happening in that CYP social prescribing space. So yeah, really insightful, kind of different take on how that social prescribing looks. So next up, I'd like to pass on to Louise, who is a health and wellbeing coach at Broxbourne Alliance Primary Care Network. Louise will be outlining the day-to-day for a health and wellbeing coach and how she is able to work with patients effectively.
Has that worked? Hello. So my name is Louise. I'm one of the health and wellbeing coaches at Broxbourne Alliance. And just to go through quickly what my day-to-day looks like and how I sort of differ from the social prescribers. My focus is pretty much predominantly on exercise and nutrition. So we can get referrals from, well, I personally get referrals from pretty much across the board. So nurses, physiotherapists, the GPs. Usually the majority of the patients that get referred into me will be for things like either pre-diabetes or diabetes, high cholesterol, the management of menopause, PCOS, endometriosis. We get quite a few low moods, anxiety, depression, but also I would say the majority of the cohort of patients that get referred into me tend to be around weight management. Weight management is a very sensitive topic. I think a lot of people just oversimplify it and they will start signposting patients into physical activity providers. They'll send them leaflets on how to eat more protein and how to stop eating when they're bored. I found that in my time of working people with weight management, it is a much more nuanced, but also, like I said, quite a sensitive topic. I would suggest that the majority of patients that we work with tend to know what they need to do. The more that you speak to people, they're aware of the things that they're either doing or that they're not doing. I think signposting is really effective, but a huge part of our work, and I would say the success in our work, comes from building that relationship with the patient. For a lot of patients that I work with, it's not just a case of telling them to eat more protein because it will make their meals, leave them fuller for longer and then they won't be craving as much. It's things like managing stress, it's time, it's finances, it's self-belief. A lot of the time, I think we downplay the importance of self-image a lot of the time. For example, if you have a patient who comes in at 55, has never exercised, has never been led to believe that they were any good at exercise, because particularly growing up from school, it used to be the sporty kids, the ones that were going to go on to do well in sport. That's where the gyms were and that's where the sport was. For them, they weren't sporty, so exercise has never been on their radar. All of a sudden they're going to the GP at 55 and they're being told to go and sign up at the local gym. You've got a lot of unpicking to do, particularly if that person has already sort of subconsciously labelled themselves as just not a sporty person. There's a huge amount of confidence that goes into it as well. So just being handed a leaflet to, go and try all these things in the area is fantastic. But ultimately, are they going to do it, or is that leaflet going to be put on the side at home? That's another thing. I think with weight management as well, you've also got particularly for women, because I forgot to mention, a large percentage of the patients that I work with are women. They do have damaged relationships with food. They may have tried, untold amounts of diets in the past, from anything from the juice diets, the Cambridge diets, the egg diets. They don't have a good relationship with, trying to lose weight, because a lot of the strategies that people have used up until, I would say, the last 5 years, they have been extreme, they have been miserable, and they haven't been sustainable. So again, sending people leaflets on how to diet, they will just say, I've tried it before, it hasn't worked, because of that sort of recurrence of the yo-yo dieting, losing the weight in an unsustainable way, putting it back on, again, just sort of feeds into this narrative that people are unable to sort of lose the weight and keep it off long term. So we do really try and stay away from even talking about dieting on the first consultation. So we do our consultations over the phone, we do them via video, we can go to patients' houses if they would like, and we really, for the first consultation, we sit down, we speak to them, we get to know them, we don't start talking about protein, we don't start talking about refined sugar, starting to understand and unpick the behaviours, because for the majority of people, let's say over a period of 5 to 10 years, if they have gained an amount of weight that is now putting them in a position where their health is being compromised, it's very rarely on purpose. It's not been done intentionally. So it's trying to unpick as to why this happens. It might be emotional eating behaviors. It might just be a complete lack of understanding, sedentary behavior, a really, really busy job. They might have 3 kids, 4 kids. They might be a single parent. They might have caring responsibilities elsewhere. So really just trying to build up that picture and then focus on the problem and the challenges that they have, because yes, they might not be eating enough protein, but realistically, why is that happening? So where are their responsibilities? Why are their meals, potentially not contributing to their health? So we do the one-to-one consultations, and we will work with patients. We say rule of thumb until we feel that they've made progress. Some patients, it might be a case of we'll speak to them, it's really just pointing them in the right direction. They're very self-motivated, they've got time, they've got the capabilities there to go and do it on their own. They will come into us, they will be signposted, and then we will check in with them in a month or 2. Other patients, we might need to do one-to-one consultations with them on a weekly basis and then start to feed off after that. But because the main cohort of patients that I work with are female, we also do VGCs. So I run my specialist is in hormones, so endocrine. So I will run a menopause VGC, everything holistic. So it won't be anything to do with HRT, but looking into, why our bodies change as we go through menopause, understanding that it's not just across the bridge when we come to it. Particularly in healthcare, we are very reactive. The 55-year-old who's now got osteopenia and has gained 10 kilograms, that tends to have been happening over a period of time, starting sort of late 30s, really early 30s for some. You start to see that muscle loss, you start to see the loss of bone density from the age of 30. So really starting to educate people on how bodies change and the impact that that's then going to have on things like insulin sensitivity, cholesterol, etc. And then how we can make changes to our diet in a sustainable way. And then my undergraduate was in neuroscience, so I do always like to sort of bring that side into it, because a lot of people love information. They don't necessarily always go and execute that information. So just trying to help people understand how the mind works, how our behaviors work, and why, we do behave in the way that we do, and ultimately how we can change that. We also have another health and wellbeing coach. Her speciality is a lot more on the mental health side. So we actually just recently ran a men's mental health project, which was 6 weeks. So GPs, physios, anyone as part of the PCN could refer into it. I did some nutrition, I did some exercise, but we also had Mind come in, we had Samaritans, we had the men's shed, and it was really lovely because the sessions actually continued after. They wanted an extension of the program, and we had a real mix of patients from all different backgrounds, from all walks of life, and eventually they actually started taking the sessions themselves. So it was pretty much self-directed by them, whatever they wanted to talk about, experiences they wanted to share. So that was a really, really lovely project that we put together, and we had 100% retention rate. We were a little bit skeptical on the first one that we ran, But everyone came back. They came back every single week. We had patients that hadn't left their house in 2 years. All of a sudden were coming every single Monday to Cheltenham Football Club. And then we ran a second one, and that was even more successful than the first. And they still now meet regularly off their own back just to get together and have a chat. Another big piece of work that we're doing at the moment as well is reduction in frailty and hospital admissions. So we did actually partner with Heart Sport Partnership for this, and they basically allowed us to get funding to qualify as a strength and balance instructor. So I've done that qualification, and so has my colleague Gemma. So we run our strength and balance sessions out of Cheltenham Football Club every single Tuesday. The group has just multiplied every single week. I think we're up to about sort of 23, 24 now. We're reaching max capacity. It's a really, really, really lovely group. I mean, I try to stay away from the classic group setting where everyone is just sort of copying the person at the front. It's very individualized, it's very bespoke. We do have a couple of people helping out just so that we can get people in different areas, because we do have mixed abilities, and I didn't want it to become sort of a mundane turn up, copy and leave. We really wanted to get people to understand why they were focusing on certain exercises. So we might have like a squatting station for certain people, we might have a calf raise for station for someone else, but they understand why they're focusing on that particular exercise and exactly how that's going to translate into everyday life. So if they're struggling to put on their socks at the moment, they really need to do a lot of hip flexor work. If they're struggling getting off the toilet, then they know that they need to be doing a lot more squatting, so they can see why. And I think that's why we've had such a good retention rate, and why people are now bringing friends and sisters, because they're seeing the relationship between exercise and everyday life rather than exercise and sport. Because when we first started referring people in and we would speak about exercises, they would sort of poo-poo it and say, no, my sport days are over, da da da. And we would kind of go back to that and say, yeah, but your days of getting on and off the toilet probably aren't over yet. So you're still going to need to do that. So you still need to be squatting. And you can start to see when they're coming back and they're noticing these differences in their everyday life, it becomes so much easier to stick to something rather than, yeah, I've got my physio send me to the strength and balance because my knee hurts. They know, and they can start to see the impact that this is having in their everyday life. So the retention is really, really good. So that all in all is kind of my role, but it's very like I think it was mentioned earlier, the role was being creative. That's the best way I could describe it, because for every patient that comes in, we might see a challenge that we don't necessarily have or have worked with before. So you go and you create something that's going to help support that patient. And that's why I love it, because it's not sort of a cookie cutter method where you come in, we give you the kind of classic, we'll go to this. If that doesn't work, you know, we'll refer you somewhere else. You really do have to get creative with it. If you need to meet people out in the community, if you need to take them to their first strength and balance session, if you need to meet them at the gym, if you need to make an introduction. I've gone round to people's houses before and literally opened their cupboards up and pulled things out and said, right, you can make this, you do this, you can do this with your chicken. It is literally hand holding to the, you know, absolute. I say to people, you're going to regret being referred into me, because I will be hanging over you for the next 6 months. But you just get to help people on such a one-to-one basis. We do the group stuff, but yeah, I mean, I love, if you can't tell, I do really love my job. And yeah, the collaboration and preventative work is the pinnacle of what we do.
Thanks so much, Louise. I wonder if you could just hang on, because I was just going to kind of really get that clarity between the difference between the social prescribing link worker and then the health and wellbeing coach. Would you say it's more the kind of content and delivery, so the fact that you might go and deliver something yourself, whereas a social prescribing link worker might refer them to do something?
Yeah, so the social prescriber that we work with are fantastic. So they do a lot of referrals, but I would say that there's an element, and I think this is why it is a bit confusing, and I don't think that there's a right answer as to who does what. I think everyone wants to help so much. I would say the difference in our team between the social prescribers and the health and wellbeing is I can give a lot more specific advice. So I can kind of tell people what to do. I can go around, talk to them about their food, change their meals, track their measurements, look at their blood work, etc. Whereas the social prescribers, I guess, are trying to increase a person's access to community, if that makes sense. Whereas I'm trying to go into the individual and make direct changes to their food, to their exercise, and working with them. But there are elements of that the social prescribers do as well. I don't, as a team at Broxbourne, we all sort of help as much as possible. It's not sort of, this is your side and this is our side and no one talks about it. We tend to do joint visits as well. So for example, if we went to visit a patient, social prescriber was there, health and wellbeing, the social prescribers might talk about more about the finance and filling out the forms and access to things, and I'm the one rummaging in their cupboards looking at what they should be having for dinner, essentially.
No, that's really, really helpful. Thank you. I just know that, you know, all of the different roles, they all merge quite a lot. And
They do, yeah.
as you say, they look very different in different organisations. So no, that's
Mhm.
really, really helpful. Now we are going to move on to the case study section. Louise, I'm just checking, but I feel like you covered your case study section there, but did you have anything else?
No, I do have case studies, but I
Okay,
can
awesome. We'll
speak quicker.
move on to those then. Perfect. Right. So yeah, hopefully everybody now feels like they have a little bit of a better understanding of some of those roles within personalised care. And I think that as we've kind of just spoken to Louise about, even if you work within that world, it's still quite overwhelming and confusing, and you know, it looks very different in different settings. But most importantly, and I've already seen some questions in the chat about this, is get to know your local health professionals, find out what their role is, and how you can better connect with them. Get in touch with your local GP surgery if you want to find out, or maybe you can contact myself and Tom within the health team and help set up a conversation. I'm not saying we've got all of the links to them, but we've started definitely doing a good lot of mapping around those personalised care roles. So hopefully we can help being a bit of a connector there. So we're now going to take a look at a series of short case studies. I know Caroline already mentioned one within a few within Hatfield. Some of these might not seem 100% replicable to you and your activity delivery, but we hope that you can take some top tips away for your own work. So just finding some little nuggets in there of information. We'll then be collating these recommendations for some takeaway next steps. So I'm going to hand back to Inez, who's going to take us through a case study with a young person. So if your services are working with children and young people in those audiences, yeah, there might be some nuggets of information there for you. So Inez, over to you. Oh, I think you're muted. Inez, I think you're just on mute.
There we go. Sorry about that. So this case study is about child S, and he was referred into YouthLink by CAMHS crisis practitioner through our referral pathway. And he had presented himself in A&E with concern about persistent low mood, suicidal thoughts without any action or any plan of action or intent, and self-harming. So on paper, it seems like he needed further support than what I could offer him. However, upon triaging the parent, it wasn't the case. So he was accepted onto the programme, and at school he experienced bullying by his peers, and mum said that he didn't have many friends, which in turn caused low self-esteem and a negative self-image. He suffered with many panic attacks at school and anxiety, which in turn stopped him from going to school as much. But during the one-to-one sessions, we obviously put coping strategies in place to help with his panic attacks, and we spoke about improving his self-esteem and making sure that he viewed himself in a more of a positive way instead of a negative way. And alongside this, he shared his love of football and Watford Football Club, and wanting to play football again. So I signposted him to Kicks, which is a football programme offered by Watford FC Community Sports and Education Trust, where he began to attend football sessions on a weekly basis. He created friends with the people that attended the programme, and he developed a good relationship with the coaches, which helped him tremendously when building relationships, building his self-esteem and confidence. And in turn, he decided to study for coaching at West Hodds College, and he is looking at coaching work experience with us. So he's done really well, and sometimes the young people are here for 6 months for one-to-one sessions, but this particular young person, he needed further support, so he stayed for a longer period of time. But yeah.
Awesome. Thank you, Inez. I think it's really important to know that, this is Watford Football Club, and there might be other people on the call who are from your own organisations, and whether that's a club or, a leisure operator. And it's kind of then thinking outside the box of, is there another pathway, another avenue that you can offer that might replicate something, maybe again, like not exactly the same, but replicate an example of something within like the case study that Inez has presented today. So it's just taking away those little top tips. So thank you. I'm now going to hand back to Louise, who is going to just go through a few more case studies. And, she's got a lot of background in physical activity, and this is very much a passion that's embedded into her health and wellbeing coach role. So Louise, back to you.
So one of the, I am on. One of, I think, my favourite case studies that we have actually is not a woman. It's one of the gentlemen that comes to our strength and balance class. He's an ex-army veteran. So he was a physical trainer in the army, was originally picked up for low mood, suffering quite badly with it. And our social prescribers set up a local veterans cafe. So it's one of the churches nearby. It's a huge group now. I think they sometimes can get up to sort of 20, 25. They've got a WhatsApp group. They meet outside. It's sort of like we set up these groups, and then all of a sudden they don't want anything to do with us. They're a really, really lovely group, and he actually got signposted to the strength and balance because he was really struggling with just day-to-day activities like putting on his socks, and his children were noticing that potentially there was going to be a bit of a decline there. So he started coming to the strength and balance, and after the first session, I mean, he just left with this enormous glow on his face. It was really, really lovely to see. And he just said, this has taken me back to, when I was younger, that feeling that physical activity can give you. I've got a focus now, and within sort of 2 or 3 weeks he was putting his socks on, he was coming in without his walking stick. He still uses it intermittently, but nowhere near as much as he used to. And I noticed that at the Veterans Cafe he was like talking to lots of the other participants and really encouraging some of the physical activity. And he came back the following week, and I was helping a gentleman that was on the other side, and I sort of turned round, and he'd taken it upon himself he was going round, as much as he was there for himself and I was sort of encouraging him to do it, he was all of a sudden sort of stepping into that physical trainer in the army and looking at everyone else and giving them advice, etc. And he's now a physical activity champion. So he got his award, I think last week, was it, Zoe?
Yes, I live from the Better Celebration event.
Yes. So he got his award last week, and a lot of his friends, when I'm speaking to them at the Veterans Cafe, they cannot talk about enough how much of a spark it's sort of given him. He's got a focus. He's going home. He's asked me to print off some anatomy pictures for him so he can learn the different muscles. And he's now even gone to the Veterans Cafe, being supported by myself and the other strength and balance coordinator, and he's running his own strength and balance at that Veterans Cafe. So we've now got a patient who is sub-delivering this strength and balance to an additional sort of 20 or 25 patients that we wouldn't have necessarily seen or moved that day. So that sort of drip feeding and the way that he's enjoying it is so infectious, because people are now looking forward to his sessions. They're then going home. One of the other gentlemen came in and said, oh yeah, I was telling my neighbour about that, and he came round for a coffee the other day, and we did a couple of these exercises, and I told him if he's struggling with his hips, he needs to do this. And I think for me, that's what the physical activity is about, because if you've been sporty from a young age, you're going to get that natural fuel for it. But I think it's understanding that not everyone is always going to have that. Some people really hate sport, some people really hate exercise. I've trained people in the past for years, and they hate the pain, they hate feeling out of breath, they just don't see any enjoyment in it. And it's okay to accept sometimes that not everyone is going to love sport, but if you have people that do, let them sort of spread that infectious energy. But if you've got people that you're really struggling to motivate, and I have had people that I really struggle because they just don't find the enjoyment in it, which I sometimes find hard, it's just about taking it back to everyday life. If you're not going to enjoy it, you're not going to be competitive, if you're not going to play the sport for the fun side of it, you've got to just always come back to that everyday lifestyle, how it's going to help you, because the way that John does it with some of his peers that have zero interest in sport and have never enjoyed it, you can see them, they sort of, all right, I'm not really listening to begin with. But then when you link it back to that, getting up and off the toilet, getting in and out of bed, putting your socks on, all of a sudden you've got 25 people in a room that are all taking part in physical activity. And that for me was where it was really powerful.
Thanks so much, Louise. I think it just shows the power of physical activity. And, you know, I know we use the term sport, but it's really just about movement and getting people out there, and shows the power of, you know, any of the physical activity providers on the call today, what that can give you, and also what a rewarding role that is for you and all the other personalised care staff that we've got on the call today. A really, really rewarding role. So thank you very much. Now we were going to be joined by another case study, and our speaker unfortunately had to cancel due to some work commitments. So I am going to ensure that case study gets shared with all attendees post-webinar, as this was going to be, so it was Ollie from a gym in Bishop Stortford called Vision Fitness, and he was going to be explaining essentially from the perspective of a physical activity provider rather than from the personalised care side. But he's built a brilliant relationship with his local primary care network, and I know we've got representation from Guppy on the call today, and they were able to receive funding from their primary care network to set up a physical health coaching programme involving patient referrals from the local surgeries, social prescribers. This case study has some brilliant insights to take into your own practice, so I will be sure to collate this in a format that we can share with you all after the webinar today. Now then, as we close in on what's been a really insightful, or hopefully for you, insightful webinar. I've already seen some really good comments in the chat. I hope you've got a better understanding about that landscape of physical activity and how this might look within your own physical activity setup. And to bring this back into focus, we'd like to finish off with some priorities and recommendations that you can take into your own delivery to better connect with personalised care. So without further ado, also, I should just check, we're collating lots of questions into the chat. Keep dropping your questions in and we'll come back to those at the end of the webinar. A lot of these recommendations were collated from, I know I mentioned at the start around these steering groups. So steering groups with both local social prescribers, but also local physical activity providers. So I think particularly from that social prescribing perspective, a lot of these tips have come from their experience of when they've referred into these physical activity settings. So it's not an exhaustive list. There's many, many more tips out there. These are some considerations to just get you started, which factor in those local personalised care staff experiences. So I'm going to start off with thinking about upskilling opportunities and training. So if you want to connect with personalised care, you're likely going to be encountering individuals facing significant health challenges and therefore need to prepare for that within your approach. And I think we've already heard a lot about that from our speakers today. So we'd like to make a consideration around the training and education for the physical activity sector and to better understand some of these long-term health conditions. The ones that were most prevalent when we were speaking to our social prescribing steering group were particularly around mental health, respiratory conditions, diabetes, and musculoskeletal conditions. And essentially how to exercise safely with those conditions. So the conditions mentioned, were some of the most prevalent, and we've collated a few examples here. Again, not an exhaustive list, but some examples of how you might choose to upskill yourself and your staff within your own sporting organisation. So first of all, we've got Moving More. So you might have heard of our Moving More activity finder, but there is more, and we'll be touching on that later as well. But there's more to this, there's more web pages, and we've got a lot of condition-specific resources around specific exercise advice. And so whether that's you're suffering with arthritis, COVID recovery, heart disease, asthma, osteoporosis, so many different things, you'll be able to find condition specific advice on how to exercise safely. So yeah, definitely check out those pages. We'll be sending the slides out, but we'll be sending a lot of these resources in an email to all attendees today. So don't worry, you'll get all of that information. I've also highlighted on here some of the e-learning on offer from Activity Alliance, who focus on how to deliver an excellent service for disabled customers. This e-learning does come at a small cost, but it comes with that CIMSPA accreditation, so you really know that you're getting that up-to-date, crucial knowledge for your own delivery. Then looking at one more, we look at that kind of older adults focus. So our Live Longer Better in Hertfordshire team here at Heart Sports Partnership have a huge resource bank of masterclass webinars So topics such as reducing the risk of falls, frailty, dementia, or getting active with hypertension. There's an endless list of webinars, and they do lots of different events. And so really keen to, share that with you so that you can either catch up on some of those webinars, but also reach out to our Live Longer Better team to see if there's any, specific advice that you can get around that inclusion for older adults. And then in a similar vein, I've also included We Are Undefeatable, a collective movement supporting people with a range of long-term health conditions. So they have a wealth of resources, and specifically for the We Are Undefeatable movement in Hertfordshire, we hosted a webinar previously that you can still catch up on, focusing on getting active with long-term health conditions, so including dementia, diabetes, arthritis, Parkinson's disease, and mental health. So again, a lot of good tips and tricks in there for you to take into your own practice. And then we've heard a lot about the prevalence of mental health, particularly within those children and young people settings. So for those welcoming individuals into their activity spaces who might be struggling with a mental health condition, Mind teamed up with UK Coaching to offer an e-learning course. This has been available for a long time, but it's a really good long-standing e-learning course to increase mental health awareness within sport and physical activity. This course comes with CIMSPA CPD accreditation and can be done in your own time. So really getting your staff to complete that would be a really nice asset to your delivery. We've then also, there's so many resources that we could have focused on. The last one we've chosen to highlight are the resources for getting active with cancer. So what the benefits of physical activity are for cancer, being active before, during or after treatment. And I think that goes to show for a lot of long-term health conditions around that pre and post surgery. And there's a lot of advice around there about how physical activity can really put you in the best state for getting that surgery and your chances afterwards. So as I say, there's so many different more resources out there, and we can always point you in the right direction if you're looking for a specific individual that you want to cater for. So please do reach out to our team. And then with all of that training in mind, this also leads us on to understanding your participant better and really what motivates them to join your session. So let's say that you've had, Louise, your health and wellbeing coach locally, who's referring somebody into your session. You just might want to increase your provision a little bit better, understand exactly what motivates them. And in our discussion with our steering groups, we considered the following questions that might be relevant to our short participants upon joining. So this might be achieved by an actual questionnaire that you give them on their first session, or it might be achieved just through a conversation. So I'm just going to pick out a few examples here, for example. So, definitely getting to know their current level of physical activity will help. Are there any particular movements that they find difficult or need to avoid, or particularly anything that they might feel anxious or worrying about the class? And that might not be the physical activity itself. It might just be the group environment. It might be who maybe the leader is. I know the case study that we couldn't have today from Ollie, he was, definitely going to talk about the provision that he has a lot of different leaders in the group, female, male, whoever that might look like, so that he's got different people suited to the clients that he's getting into those sessions. So what types of activities have they enjoyed in the past, if any? I think really helping to reach on those vicarious experiences that they've enjoyed in the past and trying to bring that into your own delivery to help that session. And so this text is really tiny now. So any what would a successful experience in these sessions look like for you? So what is going to make them at the end of your session think that was really well worth me coming? That's exactly what I wanted to get out of it. So I think just consider some of these questions, bring it into your practice. Some of you, particularly maybe leisure operators, might have, some of these questions anyway, particularly within their exercise referral schemes. So some of you might be doing this already, but there's definitely some more considerations that you could make within your practice. So I'm now going to pass on to Tom, who's going to talk about a bit around promotional messaging.
Thank you, Zoe. So yeah, another thing that was outlined by the social prescribers and link workers we spoke to was around how sessions are marketed and really making sure that you're promoting an inclusive environment if you're looking to reach the kind of patients they're working with, and thinking about things such as whether it's taking into account health literacy, reducing jargon and making sure that people can really understand what the sessions are involved, taking into account that the average reading age is 8 to 9 years, so avoiding complex words and overcomplicating things, but also thinking about the imagery of your marketing So there's resources such as We're Undefeatable, and they have an image bank. So it might be a case that rather than having something that's super active, if you're looking to engage with people that might be coming from social prescribers, link workers, or health and wellbeing coaches, but actually the images that you're using, you don't want it to be really high intensity. You might want something that's more accessible to them and something they can relate to more themselves. Other things as well is kind of just making sure that you're really accounting in terms of what the session will involve. Is there kind of how you can say someone will be there to meet them, just making sure that it's really not maybe focusing on the sport as well potentially, so looking more kind of, we've spoken throughout this maybe more around movement, physical activity, always thinking about the wording and who you're actually looking to market to, but also making it really promotional and engaging in all that you're doing. Just go on to the next one there. Also talking about inclusive activities, so Zoe touched on it a bit in terms of kind of that upskilling element, but actually thinking around who your activities were inclusive to, and going back to the marketing, it's being really clear within that who it's inclusive to. But actually what we wanted to do is bring resources around inclusivity to this group. So it may be a case that you want to make it inclusive to people with disabilities, and Activity Alliance have a range of resources which can build into that. We've spoken a bit around a lot of the people, or the patients that the social prescribers and personalised care are seeing might have mental health challenges. You might want to visit the Mind website and kind of look at what is important around people with mental health conditions. Mind have developed a resource all around making sport and physical activity sessions inclusive to mental health challenges. Maybe aware of people with neurodiversity. Neurodiverse sport have activities as well, or resources that you can use. UK Coaching, they have a wide range of resources and training that are available. So I think it's just really utilising the resources that are out there and being really specific in who your activities are inclusive to. Going back to that marketing, or kind of when you're speaking to link workers, personalised care, actually who your sessions can cater to and what's involved, and maybe just thinking about yourself. If you hadn't considered it in your initial activities, what else could be done to make them more inclusive?
Brilliant, thanks, Tom. So we're now going to look at a little bit around those referral processes and pathways. And I did see a comment in the chat about this, so hopefully we're answering your question now. So those working in personalised care, I think, as you've probably seen from what they've mentioned, they have a really tough job to keep up to date with all the different activities going on. Not just physical activity, you know, there's so many different channels that they can refer people to. So for us to make it as simple and easy as possible for them, we've collated some of these various different referral pathways that you can make sure that your activities are showing on these directories. So we've got 3 county-wide directories. So we've got the Hearts directory, Hearts Help, the Moving More Activity Finder, and then we also have Frontline, who show activities being offered within Broxbourne, and then there's also a separate frontline for East Hearts, so 2 separate frontline sites for each of those localities. Just gonna scroll down my notes here. So to start off with Frontline, so just so that you know exactly how you get your activities showing on these sites, and I'll share out all of this in an email afterwards in a little bit more detail with some of those specific links and emails that you might need. So for Frontline, you register online and a member of the team will be in touch. They also have a contact number and email to get you your activities uploaded. So I'll share those details with you post this webinar. Moving More is our activity finder. And this is powered by open data. So the power of open data means that classes listed will reach more people. It's also free advertising for your sessions out there. And Moving More is a really, really useful resource for social prescribers, as it will only show live activities. So a social prescriber will never really be in danger of referring somebody to a session, let's say a Pilates class, which ended, you know, a week ago, 6 months ago, whatever. So they know that everything's live and up to date, and that's going to be a really valuable resource for them. So there's various different ways that you might want to upload your sessions, and we've got a really nice, clear web page that will detail how to do this. because it might work differently for whether you're an independent activity provider, but also whether you're maybe, a wider leisure provider. It essentially means that your booking system might be open data enabled or not. And I won't go into all the nitty gritty details of that now because it's a little bit complicated, but you'll know what your booking system provides. Or you'll also know that if you're just an independent provider, then you'll be able to get in touch with us and we'll share those links to you. So that you know exactly how to get your sessions on there. But we've got a big resource bank already of all those activities on there. Tom and I both ourselves go out and do a lot of talks with health professionals, training them better to use Moving More Activity Finder, so that that's what they use when they're referring and prescribing to their patients. So then we move on to the Hearts Directory, and you'll need to register your organisation, and then once you've got a login to your account, you'll be able to add a specific service. So some nice, easy, straightforward steps. And they also have a printable step-by-step guide as well as a YouTube tutorial. So they make it really nice and easy to add a new listing. So it's not just adding your sessions, you'll then be able to add gradually your new listings as you have them. Now I know that Guppy, your local social prescriber, has already put in the chat how she uses a calendar, but also like a WhatsApp group. So I'd also recommend reaching out to a local social prescriber, health wellbeing coaches, etc., to find out if they have their own directory. So Stork Valley and Villages PCN have a series of WhatsApp groups and chats with various providers in their area. This is a really easy way to leave updates. So, the session won't be running this week because of X, Y, and Z. So, that's a really nice quick win that that your social prescribers know straight away not to refer their patients to that session that week, or just let them know. So if you're unsure how to connect with them, please reach out to myself and Tom, and hopefully we can point you in the right direction. Now I know the only one that I haven't mentioned is Hearts Help. So Hearts Help on there is they typically use, so I've spoken to them, they typically, for any of their physical activity referrals, they will use Moving More Activity Finder. So there's no need to get your activities showing on Hearts Help. The main thing to do there would be to get your activities on the Moving More Activity Finder, and that's where they would use for those referrals. Hopefully that helps with a little bit more, but I will detail all those different links that you need in an email afterwards to you all. So the next recommendation that we wanted to focus on, which really came out strong in the conversations with personalised care, was around bringing activities into your local community and really taking advantage of some of those community assets. It makes those physical activities a bit more accessible and, sometimes much more inclusive. Leisure centres, are absolutely brilliant for some people, but let's say that someone, doesn't want that maybe competitive environment all of the time, or maybe they just want to be, outside in the open, using a nice space. So we've kind of just listed a few examples here that might include. So you've got your library spaces, community centres, those community halls, faith centres, might even be a GP practice, parks, and really taking advantage of those green and blue spaces. And I think particularly with those parks, green and blue spaces, you can get free activities. So when that cost becomes an issue, which we'll touch on later, they are some brilliant spaces to use. We've got some excellent examples from across the county where this has worked well. So we've got some local GP surgeries offering Pilates classes and walks from their surgeries or within their surgeries. We've seen leisure centres partnering with mental health swims, so it's providing peer support swims and dips in the community. And we've also seen fitness and yoga instructors bringing their classes to local community centres and to green spaces. Sometimes a gym, leisure centre, as I say, might be that competitive sports environment that might be intimidating to some. So let's just think about where we can bring that into a more familiar setting to those individuals, and where it might become a little bit more accessible. So it doesn't mean stopping your delivery where you're doing now, it just means opening those doors and allowing it in a few more areas.
One of the things that actually came out as a barrier for a lot of the patients that are being seen was around transport and getting to physical activity sessions. So I think it's just being aware of this as a potential barrier, and maybe providing as much information about traveling to your sessions as possible. If you've got a website, can you list local public transport routes? Is there information that you can share about that? But as well as public transport, we also wanted to just flag community transport that is available in Hertfordshire, in case you can potentially signpost potential participants or maybe build relationships locally to you to make that link that can then be offering transport to your services. So community transport Hertfordshire, has a website which collates a lot of the transport options. So a lot of the community voluntary community CVS's, community voluntary services, get my words out, provides various transport options. So there might be one local to your sessions that you can build a relationship with, or at least flag to potential participants. And as we say, we'll send these links out after. As well as the Community Transport Hertfordshire, there is also, on the next slide, Zoe, the Herts County Council link service. Again, the link service is a bookend platform which potential participants might be able to book the link service on the website we provided, providing a pick up and drop off in various locations across Hertfordshire. So again, if you're coming into contact with potential participants and they're flagging transport as an issue, it might just be something that you can identify and share with them, or as I say, potentially build those relationships to see if they can link it with your activities as well.
And then the last one that we wanted to touch on was a cost. And I think this has always been, a big barrier for people. But as I think it was Tracy at the very start was kind of talking about that perceived cost as well. There are lots of free activities out there that we utilising those green and blue spaces. Now, we've broken down a couple of different examples now for how you might be able to make your sessions a little bit more accessible in terms of different your cost of sessions. Now, it's all well and good asking for cheaper or free sessions, but we know that this isn't a feasible option for many of you on the call, obviously. So there might be a few options which might entice someone to access your sessions if they had financial concerns. So, for instance, are there options for a free taster session? Somebody might just want to dip their toe in, see what it's like before they make a big commitment. Do you offer maybe a discounted scheme for certain individuals, so those living with a long-term health condition, or those being referred by a social prescriber perhaps? And I know that, for instance, we've got the exercise referral schemes out there that play a big part within that. Can people pay in instalments if they need to? Or do payment options allow for flexible attendance if somebody can't attend every week? And I think that's definitely, that last one is something that those social prescribers have seen, is that, a regular commitment for somebody going through all of these different things in their lives and their long-term health condition, and there's so many different factors to pay to pay attention to. They might not be able to commit every week. They might just want to, have a little taster here and there, or know that there's no pressure if they can't attend one week. So just a couple of considerations to take into your own practice. So I think all of those that Tom and I have just collated are just some things to think about. It may not be realistic to achieve them all in your delivery, but by doing some of these steps, you're making your sessions much more approachable and accessible and inclusive for social prescribers, care coordinators, health and wellbeing coaches to refer their patients to. So the next thing that we're going to do is we're going to move on to our questions. I think we've got to just do a little bit of a dig through the chat right now just to see what questions we've got. Hopefully some of them we have answered throughout the call anyway. I know there were some towards the start, and I'll be able to bring on some of our speakers in case they can answer from their kind of perspective. So Tom, I might need your hand going through some of these because we've got a lot going on in the chat. If you've got another question, pop it into the chat as well.
I can go through the questions though, if you want to bring people on screen, and I can read them out as we go. Perfect. So the first one I've got is, noting that cost was a barrier for many, are there specific social prescribing grants funding that groups can apply for services this route? Has anyone come across any social prescribing grants at all? Or is that not something we're...
You want me to answer that one?
If you don't mind, first.
No, that's fine. Yeah, it's a tricky one. I wouldn't say across the country there is that, but there is at the moment in the National Academy. We're doing work to try and advocate that up with Department for Health, but in some areas of the country they have set up things like community kind of grants, chests and things for activities to aid with that. So you've got different approaches in different areas of the countries, but yeah, there isn't a kind of a one size fits all to that at the moment, unfortunately.
I would also say in Hertfordshire, I'm not aware of community grants for providers, but I have heard of Herts Community Navigation Service, part of our social prescribing service do have bursaries for participants if they want to access it to access physical activity. Not so useful for you on the call as physical activity providers, but it may mean that participants can at least afford to access your sessions. I'm just going back one question. We may have answered this already, so see what you think, Zoe. So do we providers create an activity and then approach local doctor surgeries and let them know their activities? How would you advise people go around getting in contact with personalised care?
Absolutely. So I think definitely utilising some of those referral pathways that I mentioned. So if you've got your activity, getting those showing on your Moving More Activity Finder, Frontline, etc., all of those different directories. If you want to make a specific point, maybe, and let your local personalised care staff know, it might be a conversation that you can reach out to myself and Tom, and we might be able to make that connection for you. As I said, we don't have an exhaustive list of every personalised care role out there. That would be a miracle. But we have made a lot of connections through the start of our Active Connections programme. So do reach out to us and hopefully we can make those connections for you.
The next one I've got is there a specific role around neurodivergent social prescribing? I guess maybe asking the group, does this come into your role generally, or have you ever come across someone who's more specific, who maybe has neurodivergence or SEND kind of specialisms? I guess you touched on it a bit.
Yeah, so with children and young people, I have had a few neurodivergent referrals coming through, and obviously having sessions in the sense room help. But there's things that you can put in place where that could help that specific young person. But this is where the triage is really important for myself to see whether I am able to meet their needs. Because if someone's at a high need, then I might not be able to help them at all. But also it's depending on the parent and what they're willing to allow the young person to do as well. But there isn't any specific neurodivergent social prescribing that I'm aware of.
We get a lot of referrals that are people who are neurodiverse, and we've all done training over the last year and a half so that we can make some reasonable adjustments. And we've used some of that training with the GPs in each of the surgeries as well, and brought that back just to try to make sure that we can be as inclusive as possible. And we've got 1 or 2 patients who are coming with their lived experiences to share with the surgeries and with our team, so that we can look at different ways of ensuring that we're reaching everybody in the right way. So I don't know if that helps. We haven't got anyone specific though, but our backgrounds from our team are all very different. So some of us have got experience in that area, which helps.
Yeah, no, I think it's good just to know, isn't it? It's almost reassuring you've had that training and that lived experience. Coming and meeting the team is really, really good. Maybe one for Zoe. I guess what some people are asking, how do they find local social prescribers, and how do they link them to the groups? What would you say the takeaway is? Do you think that's getting in contact with us off the back of this webinar?
Yeah, I think similar to the last one, I think get in touch with us is probably your best call, and popping your sessions onto the referral pathways. But yeah, hopefully a conversation with us is definitely the start of those conversations, because it looks a little bit different for different people. Some they just simply want to be a referral, so a social prescriber can refer a patient to their session. Other times it's kind of, oh, actually, how can I get my provision of this activity, within or nearby a GP surgery? How can I set it up in a new space and get them to understand that exists, and that's something that they can refer their patients to. So yeah, it depends kind of what your call to action is, but I think definitely reach out to both Tom and I, and hopefully we can point you in the right direction.
And you'll email everyone and they'll have
Yes.
Okay.
Yeah, I will put my email in the chat as well, just in case, but everybody should get an email after this webinar with all of those details.
So the next one we might have touched on in kind of the last section, but I'll ask it anyway. How all service providers best prepare our volunteers to receive people with varied and complex needs? How do we get our mind around the segmentation of the population and build a plan for each segment Do we need to be able to meet the needs of everyone to offer our club to anyone, or should we be target a certain segmentation that we can provide a service to immediately, or our community currently underserved? Does
I'm going
anyone
to just
have a
jump in on a
go for it,
thought.
Zoe.
It might be one jump too far at the moment for somebody to just go and say, I want my session to target absolutely everyone in every sense. Obviously, that would be dream world scenario. But if you can just branch your session out to, you know, one more of those. So when I went through all of the different training examples of whether it was kind of, you know, upskilling in mental health, MSK, respiratory conditions, diabetes, etc., you could just for now pick one of those categories, ensuring that your sessions are really, really inclusive to that audience. And then it might be that in a few months' time, or, you know, whatever your timeline is, that you then start opening it up to somebody else. But I think it's small steps, and this whole point of the webinar is so that you start making those small steps, and it's not just one massive leap, because this can all be very, very overwhelming, and to do all of those recommendations in one go is quite a lot. So yeah, maybe just start with, you know, one or two of those audiences, and see where you can go from there.
Yeah, and I know this question came in before we'd done that section. I think once you've upskilled the volunteers around that particular audience, it's then being clear with what you communicate, who you are comfortable potentially taking referrals for. So it's just kind of making sure that that's clear when you make those connections to the personalised care. Just one around visibility. I think we've spoken around the ways to make your sessions visibility in terms of those referral platforms that you spoke about, Zoe. Sorry. This might be an interesting one. So it gives a specific example. Our county-wide Live Longer Better 50+ no strings badminton delivered by qualified activators has had a patchy response from GPs and social prescribers. Some are happy to refer, others would not refer because they said they didn't know the standard quality provided. How do you reassure that personalised care that you're kind of up to scratch? Does anyone, from your perspective, maybe, what would make you comfortable referring into a community session?
For me, I didn't actually know what the no strings badminton was, so I just went along with a patient the first time and had to join in. So but they actually wanted to partake in that, but it might be worth the groups coming to talk to social prescribers in the first place, so that we experience it a little bit before we take a patient there. I'm not sure if that would work for some.
Yeah, possibly making those connections. Did you want to come in, Ines?
I was just going to say the same thing. Get in contact with the social prescribers, and then offer or allow us to visit and come and see this space or the session before we refer participants in.
I've got a question around, is there a process to support service providers and clubs build a vision, strategy and roadmap that is within their reach and that creates value to their particular community? I think I'd probably just say that's one to reach out to Zoe, and she can kind of work with you around how you might make the case and start connecting to personalised care. So again, that would probably be my answer to that, make that connection, and we can support with that. And I'll try and nip through now because
I think any questions that we don't get through today, we will try and answer in the email that we send out afterwards, but also I've put my contact details in the chat, so hopefully you can get in touch with me afterwards and we can reach out to our speakers again if any questions need answering.
I missed any obvious ones.
Can't see any others, but there's a lot going on in the chat.
Yes. Sorry,
yeah,
if we
I think
we'll go through fully at the end, kind of conscious of everyone's time now.
Brilliant. So just a quick reminder that we've got our feedback form. I've also popped it in the chat as well. So if you are able to give us any feedback on our webinar for today, this really, really helps us improve the delivery of any of our webinar and events in future. So the last thing that I have to say is obviously thank you for everyone that's attended today, and of course to all of our speakers. It's great to see the enthusiasm from both the local physical activity providers and also the local personalised care staff, not just those on the webinar, but also from our steering groups. We've had some brilliant conversations in the chat today, and I can already see some connections being made of conversations that people are going to have off the back of this webinar. So please take away some of these learnings back to your own organisations. As I said, it's small steps and changes that you can start to embed. Get your sessions showing on some of those referral directories, and please reach out if you need help connecting to any of your local personalised care roles. I'll be sending a recording and slide deck following the webinar and any of the resources mentioned. So please look out for more of our work moving forward on social prescribing and physical activity. Thank you.